Hello, everyone. We're going to start with pharmacology on this session. Welcome, welcome. So our objectives here today are to demonstrate application of clinical reasoning. Remember that I will be talking about the meds and telling you about them, but I'll also be demonstrating how you would see them on potential questions when you go to take any exam and or NCLEX exam. We want to make sure you understand how to apply the knowledge to reduce patient risk and keep your patients safe. We want to make sure you can also provide early interventions given that a medication has a potential complication. So let's go ahead and start with insulin. A lot of time students think they know about diabetes and they miss some of the little details about the medication, and so we want to talk about it. Okay, so first you need to make sure you understand the difference between hyper and hypo. I'm not going into all of that, but make sure you've got all that information for you. We want to remind students that not just diabetics can have hyperglycemia. Sometimes when we put patients on steroids and or TPN, then it can cause hyperglycemia. Remember that hyperglycemia is what we're treating with insulin, but the side effect, the biggest side effect, is hypoglycemia. It is considered to be an acute emergency and can be unstable. Remember that the first three assessments that you do when you suspect someone has a quick reaction and needs treatment for hypoglycemia can be included with the 15-minute rule for treatment. But as far as what you see, right, you're going to assess their blood sugar, you're going to assess their neural status because they get shaky and have a hard time conversing, get a little bit confused, a little bit of slurred speech, right? I know what they say. Alright, so insulin is generally used for this if it's quick. You can also use anti-hyperglycemics, but I'll talk a little bit more about those in a minute. Okay, so your type 1 diabetic has to have insulin and cannot use the anti-hyperglycemics. Your type 2 can start out with either or. Right. So I wrote here the symptoms of hypoglycemia for a particular reason. You guys generally understand about slurred speech and sweating and shakiness, even clammy skin, but you forget about some of the other symptoms, and test questions don't always give you the ones that are most commonly used in the general public, given that we're trying to see if you are a safe and effective nurse. So please notice that complications include coma, coma or death, seizures, and dysrhythmia. Okay, so this chart is really important. We want to make sure you understand when the peak time is for someone to crash because we gave them medications for their hyperglycemia. You can also use this information to decide which patient to see first if they give you 3 or 4 patients that all had a different type of insulin. You should be rechecking your patient for symptoms of hypoglycemia at your peak. Remember that the only insulin we run IV is regular. Also, please remember that Lantus is never mixed and is usually given at night, but not always. Okay, so the medications that you need to take later. The TZDs, may cause effects such as swelling and edema, fluid retention. So these patients also have congestive heart failure. You want to be mindful that this medication is not given to those, given that they end up being diabetic. Most generally, they're diabetic before heart failure, but not always. So don't make that your norm. These do not cause the blood sugar to drop. It does lower the incidence of hyperglycemia by affecting your other functions instead of directly like insulin does. So the glenoids, it's been a while since I pronounced these. These work quickly when taken with meals to reduce high blood sugar levels. So this is the one that you hear about where you take it and then you take your bite. Okay. Take it, then you take your bite. I know I'm going up the slide instead of down the slide. I apologize. I just stopped the recording to let one of the dogs out. So feeling a little backwards here. Okay. Let's move on. And my slideshow is not moving forward. Pause this. Okay, so what I want you to remember about Dpp4 inhibitors is that's Januvia. Okay, we give Januvia quite a bit now than we used to. You can take Januvia with or without metformin. This does not cause the blood sugar to drop as fast as metformin does, but it helps stabilize. Okay, the alpha glucosidase inhibitors, okay, like your Acrovose, is definitely something you also take with meals. It limits the rise of blood sugar, but it doesn't bring it down, right? We couldn't use these items in an emergency situation when the blood sugar was rising or was so high that they had symptoms. The bile acid sequestration, these medications are very rarely used. They cause severe constipation. What we're finding is that the main med you'll hear is Welcall, that people are sometimes using these to lose weight, but it can cause constipation, heartburn, headache, because it affects the GI system completely. And it works with how it breaks down the food as opposed to working with trying to stabilize or lower the blood sugar. Again, remember we have combination medications, so if your patient is on that metformin or any combination of metformin, you still need to be cautious with your patients who have had any IV contrast or is preparing for IV contrast. In the notes, you will see that I listed out some names of those combination meds. Okay, now that we've got the medications and stuff out of the way, let's talk about treatment. So, insulin side effect is low blood sugar. We talked about the signs and symptoms already. So, we're going to use what I call the 15-15 rule. I was taught this way. It's not something I made up. I'm just saying it. The 15-15 rule, where you give the patient 15 grams of simple carbs, and then you recheck their blood sugar in 15 minutes and assess their symptoms. If their blood sugar is not normal or there is no symptom relief, then you would rinse and repeat. So I feel like that the biggest thing that students miss when doing this 15-15 rule is, what does 15 grams of sugar look like? The other thing is that they miss the route in which the patient is supposed to get it. You guys see the word orange juice and you jump on it, but please be mindful that there are certain sizes of everything on the hospital floor for a reason. Example, it's 4 ounces of orange juice, not 8. That is 15 grams. It is 8 ounces of milk, which is, if you open the fridge in any hospital unit, you will see there's 4-ounce orange juice, 8-ounce milks. Even the snacks and stuff are meant for controlling blood sugar quickly. We have 15 grams of that come in glucose tablets. Sometimes there's a range. Please read the bottle because different brands have different ranges of glucose. 2 tablespoons of raisins, a tablespoon of sugar or honey, hard candies. Some diabetics keep hard candies, gumdrops, sometimes jelly beans. You also have the syrup that can go on, or the syrup, that can go underneath their tongue. And then you have IV dextrose. So think about your patient. Usually the question presents to you, it's clear that your patient is hypoglycemic and you want to give the 15 grams of sugar, but you jump on the one that says orange juice, even though it says 8 ounces, or you don't pay attention that they are literally passed out and you can't give them the orange juice, right? You have to give them IV dextrose and or the stuff under their tongue. If the hypoglycemia continues after you've repeated, just keep going. If you need to double up on something, you can do that too. Once the blood glucose is normal, this is the key here, okay? In order for us to keep it normal and it not to continually fluctuate, then at this point, you want to give your patient a complex carb and 7 grams of protein. Henceforth, looking in that fridge on the unit is the same as the turkey sandwich, right? Complex carb and 7 grams of protein. This will sustain or keep your blood sugar where it's at so that you're not constantly running in and it's too high and now it's too low and now it's too high. One, that's not good for the patient. It's not good for healing, especially if they have something else going on. 2, that's poor time management. And 3, we want to make sure we're doing good things to teach the patient, and our actions are things that they watch. So we're going to move on to anti-lipidemics. So Lipitor, Zocor, and or Crestor. The 3 brands are important here because sometimes a patient does really well with one brand and not the other. Severe muscle cramps and leg pains can happen. I've seen patients get started on Lipitor and a couple weeks later the physician changed it to Zocor or Crestor because of leg cramps. So we're using this to decrease the bad cholesterol and increase the good cholesterol. It would, in the perfect world, it would be nice to have a liver function test and then be able to check it again in 12 weeks and or at least every 6 months after. If your patient has an underlying liver disorder, we want to be cautious with them in this medication. We want to remind them to avoid alcohol and make sure they understand that these are contraindicated or could possibly at risk for pregnancy depending on what's trimester they're in. Definitely contraindicated for your alcoholic with hepatitis. So leukotriene modifiers such as Singulair and most people know that this is a long-term therapy of asthma. We're going to take it once. I think the biggest thing is not to pick the Singulair when we're talking about an emergent situation. It is not going to happen emergently. It does help suppress inflammation in the bronchial tubes, and then helping decrease that inflammation keeps down extra mucus production and that kind of stuff. Again, this affects the liver function test. Clients should understand to report extreme anorexia, abdominal pain, and any signs and symptoms of jaundice. Okay. So, because this one affects the liver a little more than the other ones, then you'll also want to monitor their PT, PTT, and INR, especially if they're on any comorbidity meds like Coumadin or warfarin, or that is the same thing, Coumadin or Heparin, and Eliquis. Okay. We want to make sure we teach our patient the signs and symptoms of bleeding because the liver controls the clotting cascade. All right. We also want to teach them to rinse their mouth out after they take the dose and how to use it. Sometimes doses come in inhalers, sometimes they come in the tablet medication pack, so make sure they understand how to use them and when to use them. Magnesium sulfate. Now, most often we use magnesium sulfate for preeclampsia. Hopefully they don't get eclampsia, but for preeclampsia, we use it for early onset of labor in a pinch. We want to use other stuff first, but for preeclampsia, we're using this for the happy side effect that it decreases the blood pressure. Okay. So if you're giving your patient magnesium, you need to remember your parameters. One, meaning that if their magnesium is already high in their blood system, you're not giving it. Two, meaning you have to monitor for toxicity after you've given it. So remember, this is about lowering the blood pressure and keeping the patient from going into seizures. It has the HAPA side effect that it decreases labor. So when you want to check the toxicity early, you're going to go ahead and really closely monitor the signs of urinary output. If it starts to go less than 30 milliliters an hour, you definitely need to think toxicity. You need to call the physician or stop the medication, call the physician, and get those levels to confirm your assessment. Remember, labs confirm your assessment. Deep tendon reflexes will go down. The respiratory rate will start to go down. You'll see some pulmonary edema, and then the patient will start having chest pain. Remember, those are later, so really pay attention to that urine and that deep tendon reflexes. That will give you a clue as to this is happening. You definitely have some CNS depression here. If slurred speech and confusion is starting, and you've missed some things. We're about midway through toxicity. Remember the antidote. Super important, because when you feel like your patient is toxic, you're going to stop the med, call for help. Help it should be able to bring you that calcium gluconate. Anti-Anginal Agents. This is the kind of stuff that we give them when they're having chest pain. Not necessarily chest pain due to a clot or anything like that, but chest pain because their heart is working harder. Maybe they're a long-time smoker and their vessels are constricted, or they've had some other kind of damage to their arterial and vascular system. Mdor is probably the one you'll see the most often. Mdor makes it easier for the heart to pump. It decreases the pressure. It's long acting. The anti-anginals all have some nitrates in them, so if people are allergic to the nitrates, you need to pay attention. Nitrates is also something that you will find in those pre-workout supplements because it opens up the blood flow so that you get good blood flow while you're working out. I say that because I did have a patient who didn't know that, who was already on Mdor and then came in because they tried one of those pre-workout things and it managed to pretty severely drop their blood pressure, and we had to take care of it. We would not use Mdor with a patient with a recent head trauma because it will increase cranial pressure. Again, that hypersensitivity to nitrates, such as your person who took a pre-workout medication. This is a pregnancy risk C. We're going to be very conscious when we use Mdor with a patient who is also taking an antihypertensive or anything else that will lower their blood pressure. We don't want to cause a hypertensive crisis, so rebound. Our patient who has renal or liver dysfunction, we want to get a nice clear baseline because we don't want to mess up any of that. Since this medication will affect the blood sugar, we're going to monitor blood pressure. Not that we're not going to do vitals and not monitor the heart rate, but the blood pressure will be affected first. This would be a good medication to do your, if they're getting the first dose, check their vitals in 15 minutes. And then at 30 minutes, when you go check their vitals, again, after initial dose, you're going to do orthostatic hypotension. It's a good nursing practice. You also need to do that if someone, even though they're getting the same medication that affects their blood pressure, if it's being increased. This medication, just so you know, does not relieve chest pain. Please read the notes. ACEs and ARBs. So I put them on the same slide so you can compare and contrast. Remember, ACE inhibitors are better for your kidney patients. ARBs are contraindicated. They both have an incidence of orthostatic hypotension. They both affect the angiotensinogen 1 and 2. Therefore, you have to watch your sodium and water. And anytime we're talking about affecting the kidneys, we talk about retention of potassium. We always start low and go higher. You're going to do that rule where you check it after initial dose in 15 minutes and then again in 30 minutes with orthostatics. We want to instruct the patient that this medication affects everyone at a different rate, and you want to be mindful of all of the safety stuff, right? Rising slow, bed low and locked. Excuse me. We also want to make sure that the patient calls for help the first couple of times. Always teach a patient before you give anything that affects their blood pressure not to take the medication 30 minutes prior to or after taking a very hot shower, because that also dilates. Then they'll be the one that's naked on the floor, right? Report a cough, especially with the ACE inhibitors. Severe persistent cough that doesn't go away indicates allergy and can cause a complete reaction. Inform the primary care provider if any of these things happen to discharge or DC the medicine. So the other thing I want to teach you is a little bit of nutrition here with these two medications. If you did not know, because it affects salt and potassium, we want to make sure that the patient knows if they use any kind of salt substitute. If you read the packages, some of the salt substitutes are made with potassium flakes. Okay. Another place you can use that information with the salt substitute is if your patient is on spironolactone. Remember, spironolactone is a potassium sparing medication, meaning that the potassium will go up. And then if they're putting potassium on their food at the same time, we potentially could cause them to have heart issues. Okay. ARBs will have effect on blood pressure and then heart rate. And then use with caution. Again, it hurts the kidneys with your kidney patients. ARBs will also cause the white blood cell count to go. Remember, I tried to remind you guys that when you look at medications, you also need to look and see what labs it affects, not just because of toxicity or harm, but an overall. So if the white blood cell count goes low, then they are at a higher risk for some infections. Swelling can happen with ACEs and ARBs both. So if your patient has heart failure, a tendency to hold a lot of water, make sure it's not too bad. And then finally, one of the things you need to talk about with your patient anytime you give them something that affects their blood pressure is erectile dysfunction. I know it's not the funnest conversation to have, but it is the truest. So we need to find a nice balance between their dose to keep their blood pressure down and to be able to keep them, if they are sexually active. Beta blockers. So beta blockers, if you understand the function of them, the purpose is to block the beta 1 cells and the beta 2 cells. Remember, the beta 1 cells are in the heart, the beta 2 cells are in the lungs, so you want to be very mindful of using this medication with your respiratory patients. Congestive heart failure exacerbation, we tend not to use the beta blocker, but we will use the beta blocker once we get heart failure under control to maintain. Okay, so I know that gets a little confusing. So we can use the beta blocker for heart failure if they're stable, but if they have a full exacerbation, don't be surprised if they pause it or reduce the amount so that we can get the water off of a person. What's good about beta blockers is it can be used for a ton of stuff. Migraines, glaucoma, hyperthyroidism, fibromyalgia, all of those things we can use it for. We also can use it for dysrhythmias. We lower the heart rate, then the signal tends to straighten itself out and do better. Now, calcium channel blockers, when I say it is like a Valium, I don't mean it is a Valium. I mean the symptoms after you get it, when you look at your patient, are similar to when you give someone a Valium. Okay. Again, your asthma patient should not be using this. This is what you call negative tropics. Remember, there are ionotropic chronotropic and dromotropic, which tells you how it affects the heart. So this is making the heart slow down its conductivity, so the electrical current that goes into it. As it slows down, everyone gets a better signal, and therefore you get a stronger beat, so that you can move the blood through the heart. What I like to think about for your calcium channel blockers is we use it to treat your A's, right? So anti-hypertensive, anti-angina, anti-arterial arrhythmias, AFib, and then SVTs. Okay. So when you have a heart problem that it's the pump or the electrical current affecting the pump, and it's usually the top of the heart, like AFib, then the heart responds quicker to calcium channel blockers than it does most anything else, which is also why you tend to find that medication given IV when a patient goes into AFib. So remember, both of these meds cause bradycardia first and foremost. So if bradycardia is an issue, that means you do your safety checks. Your safety check including to check the heart rate and hold if less than 60. The next big side effect that really affects the patients is hypotension. So you want to make sure you're going to hold this med if the systolic blood pressure is less than 100. And anytime you do a safety check like that, you're going to teach your patient to do the same safety check. If a patient complains of some headache and lightheadedness and dizziness, it may be just a minute to get used to the medication if they're newly put on it. If they've been on it for a little bit but haven't been consistent and they complain of the headache, then you want to look at possible rebound hypertensive crisis. Okay. Calcium channel blockers. Often you'll see someone on a calcium channel blocker who is a renal patient to help with that pressure through the kidneys as well. Okay. Antiarrhythmics. So what's weird about classifications, I guess not weird, but what's known about classifications is you can have several meds in different classifications. For example, your beta blocker and your calcium channel blocker could be put in here for your antiarrhythmic meds. And so we need to see the difference there. We can use them for legal arrhythmias such as AFib. Each antihypertensive works a little bit differently. Clonidine, for example, lowers cardiac output and peripheral vascular resistance, whereas Cadura decreases the peripheral resistance as a vasodilator. See, it works a little bit different. Remember that if your patient has BPH, then they would prefer the Cadura. Where apressylene then is a vasodilator, right? And it is peripheral resistance decreasing, but it may increase the heart rate, where the other two do not. Okay, some examples: amiodarone, beta pace, and Toucing. You will also need to incorporate some EKG. This one will cause a first-degree heart block, so we really watch the distance between the P and the QRS when it beats. That make sure it stays good. DIG is one of these medications for your cardiac, and remember that DIG itself can have its own toxicity. Okay. Opioids, we have our agonists and our antagonists. Our agonists is things like morphine and Dilaudid. Methadone we use to replace opioid in addicts. We can use it to help them withdraw and slowly wean them off, hopefully minimize symptoms from coming down off of those things. Remember, your priority here is to, when you do a pain reassessment, that you're also doing a sedation assessment, because it does decrease the central nervous system. So your respiratory rate will go down. They'll get sluggish. If this is happening and you suspect they are accidental overdose and or they're just sensitive in response, like say after a surgery, that you have the antidote ready. Naloxone is immediate emergency treatment for suspected opioid overdose, whether it's purposeful or accidental. The respiratory rate is a big cue on needing the Narcan. Remember, when your patients are on any kind of opioid, they will get constipated. They'll need some stool softeners on board. You need to teach increased fiber and increase fluids. Anytime you increase fiber, you increase fluids, because it will cause a big brick in their stomach. In the notes, you'll notice that I talked about how it works and that kind of stuff, for those of you who really is into the A&P and the functionality. If your patient is worried about opioid addiction and they're getting ready to have a procedure that's going to cause a lot of pain, you can reassure them that as long as we're doing this for pain management, and that we can demonstrate how to maintain control of their pain levels to where they can participate in, I don't know, OT or PT, or even just getting up and moving around after surgery, is better for them than the concern for the addiction. The other thing you can do to reassure them is that you'll have a clear regimen on how to and when to back off on medications and incorporate other things like anti-inflammatories or Tylenol or something like that. Pca pump. So Pca pump, I think that the biggest thing about the Pca pump is making sure you're understanding what the readings mean and the indications of putting it on the patient for the first time and or changing the dose. It always takes 2 RNs to set this Pca pump up. We want to make sure we continue to do our frequency of pain and sedation assessment. And then what it does, it also records how many times they hit the button and actually is on a timer, so they can hit it 100 times, but it's only going to go off when it's appropriate for the timer. But understanding that if they hit that button 4 times, like 20 minutes before it's time for it, then they're in pain sooner than allotted, and you can let the physician know to see if it's okay for us to change the frequency. If it's not, then it's not. We don't want to cause any overload on anyone or have to use that Narcan. So 2 RNs have to set it up. Usually one is reading the MAR, the other is confirming the order, the patient, and then after it's put in, then they switch places. The second RN verifies that the first RN put it in correctly. Those are all safety precautions and are 100% necessary. Assess the pre-pain assessment as well as afterwards. Frequent vitals for the first bit of time that it's on the patient. Sometimes they will continue oral medications. Make sure that the breakthrough medications are placed appropriately for your patient. We don't want to cause any upset. Setup usually includes an interval a 4-hour limit. Sometimes there's a continuous rate depending on the procedure or what's going on, what's causing the pain. I can tell you that I've had multiple patients on Pca pumps with the fasciotomy, right, where they slice open your leg or your arm where your muscle is to relieve the pressure. Otherwise, you'd get compartment syndrome. Or if you got compartment syndrome, then they would cut it open. Either way. Okay. Remember, the 2RN thing happens even when the dose is changed. For the first 15 minutes, you're going to do pain and sedation and vital signs every 15 minutes for the first hour. After the first hour, you can move it to every 30 minutes, and then every hour after that for the next 10 hours. Once they've been on the Pca pump for the next 12, then you would just check it every 4 hours until it's turned off. Most of the time when we're transitioning from a Pca pump, they will use some kinds of transdermal fentanyl patch. It does take several hours for the patch to start to work, so don't be surprised if the patch is put on before the pump is 100% DC'd. Sorry, discontinued. Sometimes the physician will give you an IV push to give them while you have time for a patch to work for breakthrough when you're transitioning. So aminoglycosides. So remember that aminoglycosides treats the big bag of infections, right? It's mean and it's old. Amino glycoside treats MRSA, TB, VRE, a lot of third-degree burns. Examples of aminoglycoside is streptomycin, cliomycin, tobramycin. Notice that they all have mycin, even if it's spelled slightly different. If the THRO, thromycin, like azithromycin, or if that THRO is front of the mycin, it is not an aminoglycoside. It is a second tier antibiotic. Okay, but I want to talk for a minute about the first tier antibiotic. You need to do, when this patient is on this med, you need to do frequent checks of cranial nerve number 8. Cranial nerve number 8 is exactly the nerve that goes to your inner ear, so assess for hearing balance. Ask the patient to report any issues with that and or tinnitus. Nephrotoxicity, we want to monitor the creatinine. Creatinine clearance is best, but it takes a long time to get through, but creatinine serum is most commonly used. We want to monitor their INO, their daily weight, and then we want to draw their trough and peak levels between the third and the fourth dose, which I'll talk more about on the next slide. So that 8 is really important. You also can remember that number 8 as you do not want to give the patient an aminoglycosides on the regimen like every 12 hours. You can do it every 4, you can do it every 6, you can do it every 8, but not greater than 8. So that 8 is something you can really remember. Cranial nerve number 8, as well as every 8 hours or less. And then if we do less, you're doing that peak and trough more often. So sometimes people call aminoglycoside the liver coma, like they put it in a liver coma, which is why you need to pay attention to the ammonia. If your patient has encephalopathy, say that 5 times real fast, then we can help with that by reducing the ammonia and giving them aminoglycosides. So when we have high levels of ammonia, then the body produces E. coli, which is a byproduct, right? So as the body breaks down ammonia, it causes E. coli. Now, when we give aminoglycosides orally, then more than likely we'll want to sterilize the bowel for some kind of surgery. If we're using aminoglycosides for C. diff because the traditional antibiotics are not working, then it will help clear out the valve. So one of the ways that I remember which myosin can be used for C. diff um, is neomycin or kanamycin is the med. So I always remember neo can clear the bowel. Okay, I don't know if that helps you or not, but neo can clear the bowel. You would not be using the streptomycin and the cliomycin for bowel sterilization. Oops. Okay, so aminoglycosides. I told you guys that we would talk about this. What you need to remember about aminoglycosides is that we do frequent blood draws in between every third or fourth dose, depending on what facility you're in. Aminoglycosides, if it's given IV, needs to be given through a central line. This is the one that can cause ototoxicity, so you need to assess their hearing and their balance. Their gait will definitely tell you a lot if they're starting to get toxic. If they're on aminoglycosides too long and they get toxic, it could cause some pretty severe dysrhythmias. This will also cause renal dysfunction, renal toxicity. So you need to check the output. If the output starts getting affected here, then you want to stop the med. The best lab that we use to assess aminoglycosides is called a trough and peak. So we draw the trough and administer the med, and then you draw the peak at the peak time. Notice here I gave you the peak times of route. Most people get aminoglycosides IV. Very rarely do they get them by mouth. If they do get them by mouth, usually it's before we have some kind of GI surgery, because it will help kill all of the normal flora in the gut. Because when you open people up to do surgeries in their gut, then the normal flora, if it jumps ship and goes to the wrong place, it can cause infection. So some more endocrine medications, Synthroid and desmopressin. So with Synthroid, mainly you're going to be asked about teaching, right? Synthroid is used to treat hypothyroidism. So you'll also hear people talk about myxedema or Hashimoto's. Those are a more severe form of hypothyroidism. The patient generally presents themselves with chronic fatigue, cold intolerance, weight gain, headache, very big problems concentrating, and lots of constipation and very dry skin. Okay, so we give Synthroid. They should take it in the morning, 1 hour prior to breakfast. Very rarely will you hear that someone takes it at a different time, but prior to breakfast is best, first thing in the morning, because if you look at our body's natural rhythm and all that kind of stuff, that's when we have a surge of Synthroid naturally, if our thyroid was working correctly. So we want to make sure that we're checking thyroid medication, their TSH and all of that, to make sure we're giving them the right dose. If the patient continues to experience the symptoms of hypothyroidism, we need to increase it. As if they start reporting the symptoms of hyperthyroidism, we may need to recommend to the physician to lower the medication. Remind the patient that this medication will be taken for life. If they stop it abruptly, it could cause some severe dysrhythmias. Remember that the one thing that you need to do prior to this type of patient who is on Synthroid of going to surgery, even though it says hold all medications, prior to sedation, you're still going to give the Synthroid. For some reason, if we don't give the Synthroid and send them to surgery that day, it could cause them to go into a deeper sleep and coma, get them harder to get out of that sedation. Okay. Desmopressin we use to treat diabetes insipidus. We also can use it at cardiac arrest and MI. Most of the time, you're going to use it for diabetes insipidus. With these patients, you automatically want to put them on telemetry and monitor their blood pressure. We want to teach them the signs and symptoms of MI. Patients who have one MI are at a higher risk for recurrence. Desmopressin can cause a headache. It will cause the blood pressure to go up, hallucinations and seizures, and weight gain. Again, one more of those medications, if you're going to have to give this, you're going to put your patient on seizure precautions. If your patient has diabetes insipidus, then you're automatically going to put your patient on seizure precautions. Okay, Lasix. So Lasix, y'all understand that it's potassium wasting, so be very mindful for your patient who has that issue. If their potassium tends to run a little low and they have to be put on Lasix to get rid of some fluid, then you can teach them that salt substitute thing to go ahead and use that if needed, but not to go overboard. We can use Lasix to treat high potassium if it's non-emergent. We use it to treat congestive heart failure to get off the volume with that and edema. Nephrotic syndrome usually is the sick kidney for a while and is an acute issue, and we just want to get volume going. We want to teach to take in the morning. We want to make sure they understand that this will affect their blood sugar, that they need to rise slowly and do all that safety stuff. We as nurses, if it's a first time dose and they try to get up or go to the bathroom, you need to check their blood pressure first to see their response. We want to monitor for low potassium, tinnitus, clay-colored stools, and then sometimes we find that if they're on Lasix for long-term periods, you would have to add calcium. This could be very well contraindicated with your new moms who are breastfeeding, and it's definitely contraindicated for anyone who is in end-stage renal. Now, aldactone is the complete opposite. It is potassium sparing. So again, you're going to teach about not using those salt substitutes unless they read the container. If it has potassium flakes in it for the salt substitute, then they shouldn't be using it. We're going to be mindful with aldactone with your patients who are hypokalemic, congestive heart failure and cirrhosis, and nephrotic syndrome. We want to teach the signs and symptoms of bleeding because this affects the kidney or the liver, liver. If your patient complains of numbness and tingling in their fingers, that paresthesia, then you need to check for other symptoms of low sodium. Remember, the universal sign of electrolyte imbalance is numbness and tingling. Do not give aldactone to your Addison's patient. Do not give them to your end-stage renal patient, so anuric, they're not making any urine. Do not give them to someone who is breastfeeding and who has high potassium already. Those are clear parameters. Anticoagulation. So let's talk about heparin. So heparin is used to treat clots in the veins and arteries or the lungs. We also use that low molecular Lovenox. That's a low molecular heparin. We can use it sub-Q in the hips, abdominal area. I always say Lovenox loves the hips to remind students where to do that. It should be about 2 inches from 1 to 2 inches from the umbilicus. 2 inches is best. If you're given IV heparin, you need to be very mindful on watching for your protocol. Most of the time, protocol is based on APTT numbers. Depending on what your APT number is, every 6 hours would depend on your titrating of heparin. We can use heparin before and or after surgery as a preventative measure. But if they're put on IV heparin, it's usually for a clotting disorder. We will also put a patient on heparin if they have recovered, started with AFib, right? We want to make sure we're using this as a reduction for risk potential. We need to teach our patients about reporting bleeding. Example, if their gums start bleeding when they're brushing their teeth, which means you're also teaching them to use a softer bristle, all of the kind of stuff that you would do. Sudden numbness or weakness is something that you need to pay attention to. Any signs and symptoms of a stroke, because yes, we can use this to help lower the clots and incidence, but if a clot's already there and this starts to weaken it, it could actually have triggered something. Call your doctor, of course, if you see any serious things. Remember, it's just as important to know when to call the physician as it is when to do other things before you call the physician. Make sure all your other things are done before you call the physician anyway. In infants, this could cause extreme drowsiness and weaknesses. So we'd like to stimulate the baby a little bit more. Make sure your math is 100% correct, regardless of if they're an infant, another pediatric patient, and or an adult. Remember, 50% of all errors occur with a brand new graduate. Make sure I got my notes ready here. APTT every 4 to 6 hours and titrate the dose. I already said that. If your patient is on another form of blood thinner like Coumadin, if they're on digoxin or any of those nitro meds, then you need to be very, very mindful. They are at a higher instance of bleeding. Also, could ask your patient about any ibuprofen use because it's an antiplatelet, remember. We want them to inform us of any type of signs of bleeding. Okay. Remember that Coumadin is one of those meds that you teach not to drink grapefruit juice with. Okay. To prevent heart attacks and stroke is usually why we're given warfarin. If a patient is newly diagnosed, they go on the heparin, and then we wean them down from the heparin to the Coumadin, and then the Coumadin we try to keep them stable. The thing about Coumadin is it's not always effective for every patient. Like some patients won't take a dose every day. They'll take 1 milligram in 3 days and then 2 milligrams 2 days later and then nothing, and then start over. But they have to get frequent lab work. It's really important for you to talk to your patient about the frequent lab work. It also is important for you to look at the labs because if their platelets are low, then this can be contraindicated. Okay. PT-INR is what you look for Coumadin, and then your PTT is what you look for heparin. I always draw my PTT and then I cross the 2 T's with 1 and it kind of looks like an H to remind me of heparin. I don't know if that helps you or not, but it might. We also want to make sure this patient knows the signs and symptoms of bleeding, use a soft toothbrush, all that kind of stuff. We want to do some more nutritional teaching with Coumadin because foods that are high in vitamin K can be contradictive. Liver, really, really dark green vegetables and vegetable oil, some vegetable oils can make Coumadin be less effective, and they'd have to have a higher dose, and also could reverse it, right? Because our antidote for Coumadin is vitamin K, which reminds me, your antidote for heparin is Magnesium Sulfate. Okay. If a patient undergoes a spinal tap or spinal anesthesia, they shouldn't be taking Coumadin. If they are an unstable alcoholic or an addict, then they won't really want them to be on Coumadin unless they go, if they're taking it every 3 days or so often, they'll come to a facility to take it. Another contraindication would be pregnancy or planned breastfeeding. Anyone who is on one of these medications needs to have an alert bracelet on. So if there's an emergency, their emergency crews can see that there's a problem there. Okay. If your patient is on one of these medications and they fall and hit their head, you definitely want to do a CT scan right away. You also want to be mindful if they fall and hit their torso, that you're assessing for some underlying internal bleeding. Okay. Iron. So we give iron for severe anemia. We have to do blood work every 4 to 6 weeks when they're on iron at the initial. If they take vitamin C the same time they take their iron, then it absorbs better. Don't just focus on orange juice. Tomato juice is also high in vitamin C. They should be taking this 1 hour prior to eating, and if they take it with the orange juice, it will definitely digest better. If they're having a hard time digesting iron, because there are some deficiencies out there that they're having a hard time breaking it down in the gut, then we could give this IM. Remember that you have to give it Z-Track. This route is not preferred, but that would be your exception. If your patient doesn't take pills and they prefer a liquid form, make sure they use a straw or it will stain their teeth really bad, and that they rinse their mouth out. If your patient takes antacids or tricyclines, then iron reduces absorption, so they need to wait 2 hours. They can't just pop all these pills in their mouths at once. All of these things will cause constipation, and they will darken their stools. Make sure you teach that so they don't freak out about it. And anytime we give something that causes constipation, we want to increase fluid and fiber. Okay, we're almost done. We're getting there. Psych meds, tricyclics and antidepressants, selective serotonin reuptake inhibitors, are, in other words, SSR. Some of the biggest things you're going to see about this is making sure they understand diet. Remember that we do not use antidepressants for bipolar. It's one thing that they tend to kind of get us on when you're answering questions. The VILs, VIL, NIL, those are antidepressants. We want to make sure we're looking for serotonin syndrome. Some of the side effects are dry mouth, constipation, urinary retention, blurred vision, hypotension, cardiac toxicity, and sedation. So this definitely makes them very drowsy. When your patient's on an antidepressant, it could cause suicidal ideations if someone, especially if someone's taking it and there isn't a chemical reaction and they're not clinically depressed. So be very careful. SSR eyes block serotonin. We use that for like very, very serious major depression. It can agitate the patient, very, very, very short with people. Insomnia can cause irregular sexual dysfunction and weight gain. SSRIs, however, have less side effects than the antidepressants and the tricyclics. If you notice in the notes, I wrote more information about them. Celexa, Lexapro, Prozac, all of that is your SSRIs, Zoloft. Do not mix antidepressant meds and over-the-counter cough and cold medications. It's not very good for your sedation. And then not advise your patients not to take St. John's wort with this medication either. Psych meds continued. MAOIs have a lot of diet stuff, right? We need to avoid tyramine-rich foods with vasopressor, sedatives, narcotics, general anesthetics can cause that sedation to go so far down it will be hard to take them out of it. We would not use this medication for someone who is unstable and can't be routine with their medications. So insomnia, nausea, agitation, confusion, and hypertensive crisis. So you need to teach to report headache and things like that. Here are some examples of tyramine-rich foods. Take notes. Sometimes they show you the plate, so I wanted to make sure I gave you some things that can be on the plate. Remember I said vasopressors also, so chocolate, fava beans, ginseng, caffeinated beverages. That one would be really important to teach because it seems like the whole world is addicted to caffeine. So, antipsychotic meds, generation 1. So what is the difference between that and the others? Is psychotic meds are more about things that are completely out of control, like schizophrenia, when they go into a manic state. The side effects of this medication appear anticholinergic. So this is when you see the extrapyramidal symptoms, the tardive dyskinesia, blood pressure dropping. So think about this: if your blood pressure drops, then the heart rate goes up. So that explains the tachycardia. Nursing actions with acute life-threatening medical emergencies. So if one of these happen and they start to tank on you, then you want to stop the med, transfer them to ICU, maintain and stabilize them. Bromicropatine is given to relieve muscle rigidity and reduce fever. So we could give that very quickly. If they don't have an IV in because they're on the psych unit, then we can give it IM. Detraline we can give for muscle spasm. We want to make sure these patients stay hydrated and we watch them for dysrhythmias. Second generation psych meds also used for severe schizophrenia. What we've noticed is with each new generation that they've developed, it decreases the incidence of that emergent need like tardive dyskinesia and all of that. Labs should be baseline and weekly until they're stable on the right dose. We need to monitor the white blood cell count on second generations such as Chlorazil or Risperidone because it can cause them to have more incidents of infection. They're immune compromised. This makes you very drowsy and can cause orthostatic hypotension. So if you're doing the initial dose, again, make sure you're doing your safety checks. Metabolic syndrome is a serious problem with this. It doesn't happen as often. Like I said, each generation of psych meds, it seems like there's less and less side effects. So the one thing the farm community is doing well is making sure that they're producing medications that are effective without a lot of side effects. Shut up. Third generation then is even better. So Abilify is one that we use. Abilify is often used for psychotic conditions such as schizophrenia and bipolar. We also use this together with other medications since it's not, considered to be a little bit lighter med. Taking antipsychotic medications during the last 3 months of pregnancies can cause very severe problems with the newborn. This one has a dopamine system stabilizer. Don't forget, you're not a glorified pill passer, right? So yes, this is about pharmacy and we give a lot of meds and we're the safety gatekeeper, but don't forget about your non-pharmacological pain therapies, okay? Just a few other meds that tend to be tested on and or on your HESI. Methocarbamide, the Reglan, is used to help empty the stomach. The side effect is extrapyramidal symptoms, sedation, and diarrhea. MMR immunization is contraindicated with active pregnancies, allergies, if they've had a history of thrombocytopenia, or they're immunosuppressed, such as HIV or steroids. If they've had a recent blood transfusion or immunoglobulins, then we're not going to give them the MMR either. We need their body to adjust to the transfusion before we expect it to start building antibodies for the immunization. Program is given to Rh-negative mothers. We give it at 28 weeks gestation and within 72 hours of birth for the infant. It's been a long time since I was a mother baby, so I think that it's still 72 hours. We tend to try to give it right before they leave, before 24 hours, but you might want to check and see what best practice is for that. What this is doing is keeping the mom's antibodies from attacking the baby on the second pregnancy. And I'm done. I will do the next one later. Bye.